in the interest of time, I'm going to get started. They're going to be bringing up some more chairs because we don't have enough up here, but we'll just get going because we have a rich session planned for today. So good afternoon, everyone. My name is Olivia Velez. I'm the Director of Technical Services at PATH. If you don't know PATH, we're a health NGO. We work on health system strengthening and vaccine development and just across the spectrum of healthcare. So welcome to this session on digital public infrastructure for health. We're going to discuss a topic that's really rapidly gaining momentum and really becoming indispensable when we think about how healthcare works. So for those of you who don't know me, I am a nurse by training, and as a nurse, we often think in medication administration, having the right medication at the right time, the right dose, right route, right patient. And at the same token, we can think of data in the same way. If data is medicine, data is a healthcare intervention, and is it getting to the right person at the right time when it's needed? And digital public infrastructure is really a way to facilitate that. And Dr. Varma spoke this morning about the necessity of putting the user at the center of our digital public infrastructure efforts. And that's always been a core value in the healthcare sector, right? We want patient-centered healthcare. We want patients to have their data available throughout the life course and throughout the patient journey to really make sure that we're getting the outcomes we need and that nothing is getting missed. So DPIH is really going to be an important advancement for creating health systems that are resilient and scalable and equitable. So for today's discussion, it's really important that we recognize this very transformative potential of DPI for health, but also thinking about what we're building on in the health sector. We've worked for decades on health information exchange and standards adoption and all these things that we can build upon in this sector. I think we also have a lot of learnings about working across verticals in health that we can apply to working cross-sectorally to achieve DPIH. So I think we have a lot to bring to this discussion about collaboration and really what it's going to take to implement these systems and paving this kind of way. So for today's session, we're going to have two quick kind of lightning talks, keynotes, followed by a panel, and then some closing remarks. So our first speaker today is Garrett Mell, who's going to come up shortly. And sorry, Garrett, because I opened the wrong file. Here we go. So Garrett is the head of Digital Health Systems Unit in the Department of Digital Health and Innovation at the World Health Organization. He leads work related to smart digitizing WHO clinical and public protocols, a clearinghouse mechanism for assessing digital products against standards and specifications, and establishing a global trust network for interoperability of immunization records. And I will turn the floor to Garrett.
Thanks so much, and sorry about the formality of the presentation, but I hope at least it'll it will give us a chance to have a little bit of a starting point for the conversations, and really looking forward to the panel and the discussions as well. So I want to talk a little bit about I think the reality that in the health sector we've been really focused on the concepts of DPIs for a long time and leveraging different components in the digital in the infrastructure space. But I think it's been a recent recognition that we don't have to invent it all in the health sector, and there's really in a really important aspect of us needing to leverage the broader infrastructure that is being built cross-sectorally. Just want to make sure this works. There we go. Great. So many of you may be familiar with the global strategy on digital health. I just want to acknowledge the fact that in the strategy itself, it acknowledges the fact that there is a need to ensure that we are in the health sector building on services and applications that are that can be reused, and that we're also leveraging semantic and syntactic interoperability standards. That aspect of data exchange has always been core to how health and digital health thinks about how we build systems. But it's really a part of this strategy which was authored by 193 member states of the WHO, and it specifies the kind of actions that each member state should take, each partner to government should take, and as WHO, what WHO should also contribute to. But it recognizes the fact that there should be an architectural blueprint and that open standards are critical to the core functioning of the health sector. I want to just maybe think about some of the kinds of goals that in the health sector we think digital transformation is really focused on. I'm not getting a click. There we go. Okay, great. So one aspect is that as we think about patients, that health workers have access to up-to-date clinical care protocols, and that they also have the patient access and history, and that is really a core fundamental goal that many of the digitization approaches are trying to achieve. I'm not really getting clicks. I have to aim it? Okay, great. No more stockouts. That's a cross-sectoral need. That's not just a health need. That's something that we recognize is critically important in the health sector, but also critical to how cross-sectorally we work. The aspect of finances and ensuring that reimbursements and claims and accessibility protection for social protection is a critical part of that, and the financing and health accounts. That every health worker is a competent, credentialed, and is also paid on time. The aspect of registries become important, the aspect of financial transactions become important, and the aspect of training to support that. This ability for the system to be responsive to climate threats and the impact of climate change, and the ability to optimize against those changes. And lastly, the aspect of timely detection, assessment, reporting, and action for public health risks. So the ability to ensure that as we're surveying, we're also reporting and ensuring that we're able to act on that. And then every person has a right to their own health record, establishing trusted, universal personal health records. And these are goals that benefit from the notion of and the actions that are required for having foundational DPIs in place. When we think about a health journey, hasn't translated well here, but the patient journey, we need to know who, we need to know where, we need to know from whom, which commodities were provided, and the history and the context of that service that was provided in order to populate a personal health record. And to be able to do that, there are aspects that may be in the health sector or aspects that as registries could be in across the different sectors as foundational DPIs. Such as both as registries, but also the digital identity and the trust networks that underlie the digital certificates and signatures. So I was going to take a lot less time to get through the PowerPoint. I'm getting there. Yeah. So if we think about this aspect of how do we ensure that we're leveraging the capabilities that are available to us in the foundational DPIs, we think about the kind of goals that I've just described. Is getting to ensuring that every health provider has access to up-to-date records and a patient history. We will need to draw from the digital public infrastructure that's in the health sector, as well as those that are also in the foundational side of things. And identity plays an important role, as do the different registries and the product catalog, and of course the shared health record, which is in the sector itself. We can look at the same kind of infrastructure and the services that are available, and understand to what extent we can also populate other use cases or meta goals, such as getting credentialed, getting a competent health workforce, and getting paid on time. And it may draw from different services within the health sector. The cross-sectoral DPIs. This is really hard. And then lastly, that every person has a right to their own trusted health record, and it draws from different capabilities within the DPI infrastructure. I just want to briefly describe the fact that as an organization, we recognize that countries were wanting to exchange health credentials and know where a health record or really where a certificate originated. And so we worked with the European Commission to draw in the work that had been done in that region to leverage a PKI infrastructure called the EU DCC, and we brought that to WHO and have now called it the Global Digital Health Certification Network. And it allows us to help countries know that the origins of a health certificate or a record are coming from a trusted source. And that has applications across multiple use cases, of course, including personal health records, but also areas of knowing that a health provider has come from a trusted trainer. As an organization, we recognize that there are a diversity of foundational DPIs, such as the PKI-based GDHCN that we've established, but there are also aspects that member states are leveraging, such as in the supply chain area, and that we provide a number of services that are specific to the health sector, like the ICD codes, the content specifications in the SMART guidelines, as well as the aspects of observatory and the ability to ensure that the performance management and also registries are available to member states. In the content documentation side, we provide and make available the content that is applicable to any health information system, documenting the requirements, as well as the interoperability standards, as well as the capabilities that are needed to deliver upon any of those meta goals that I've described earlier. And we also provide the interoperability specifications in standards that are open, like ICD and FHIR and LOINC. We have lots of this documentation. I think it's important to note that as it's not enough to implement a DPI, you have to know that the content that lives on the digital public infrastructure, whether it's in the health sector or at the foundational level, is standards-based, that it's evidence-based, that it is going to function as intended. And so guidance becomes critically important here, as does the policy environment and ensuring that people have protection and safety in the health records, and that they know how to implement these systems effectively. Lastly, I'll just say, I'll put this QR code up. We're starting to do trainings of software developers as well as governments, those architecting in the ICT and the health space, to understand what it takes to implement DPIs and the FHIR standard, which is a core to what we see in the health sector, being able to bring health sector up to a state of being able to really implement DPIs effectively with a broader foundational infrastructure in place as well. So thanks so much.
Thank you, Garrett, for those remarks. So next up is Dr. Abdulaziz Suleiman Ahmad, the Chief Medical Officer of the newly launched Seha Virtual Hospital, a state-of-the-art entity founded by the Saudi Ministry of Health. He completed his medical school training at King Saud University and his graduate medical training at Baylor College of Medicine and Oregon Health and Sciences University. He holds the American Board of Preventative Medicine and Medical Informatics and the American Board in Emergency Medicine. Al-Hamoud has been integral at numerous innovative digital health projects across various leading organizations in both the US and Saudi Arabia.
Thank you so much for the opportunity. After your presentation, I think I'm just gonna bail out on the slides. That was very helpful and enough for the team. Thanks for the introduction. I kind of forgot about a lot of the things that you highlighted, but I think I did them. So almost a year ago, we had discussion with Garrett and the team about what's next. When we started the virtual hospital journey, that was during COVID, a lot of people had to change what they do. If they were not wearing masks, they had to do so. If they were not vaccinated, they had to take vaccines. If they're not very efficient, they wouldn't be able to deal with the influx of cases, the conditions, the cost. So we had to be smart. We had to be very able to accept change. And we quickly figured out how to get things done, how to dream big and start small and move fast. Before I start, because there's the room maybe allow us for a couple of different questions, I'm gonna keep an eye on the time. How many of you guys was in a mass event, mass gathering, more than 10,000 people? Yeah, 100,000? 1 million? Yeah? 2 million, right? So in Saudi, it's almost every year we have the Hajj, which is a mass gathering event. Almost 2 million people. That was 2023, 1.8 million. And they keep expanding. And with COVID, we figured that healthcare is an integral part of what we do, is core. Those are some images from 100 years ago, I think, 50s, 60s, 70s, and some newer ones. But if you, I'm trying to figure out how to manage. Yeah, but if you look at the, I'm gonna move and I'm gonna try to screen. But if you look at this slide here, the only event that changed the mass gathering event, the Hajj, was COVID. So healthcare was ended up at the center of the design, of the planning phase for the Hajj event. If you look here, we've done a lot of work around making Hajj safer, provide better healthcare, and really take advantage of technologies. In this slide, we just show the variation in the countries that pilgrimage come from, almost 150 different countries last year. But because we have the right partners, we could do a lot more. Things special to, pertinent to what we're talking about here, related to Hajj, is it's very timely. It's, there's tons of rituals that has to be delivered by almost everybody at the same time. This is just tells you the processes, the locations, different, okay? And those are some numbers from last Hajj. There was more than 90 open heart surgeries that has to be done within the 2 weeks period of time. Almost 3,000 dialysis, 1,100 cardiac cath. How can you do that to a pool of 2 million from 150 different countries? You have to do it. You have to be smart. And luckily, we know a lot of smart people. A lot of them are in the room already. We worked with our colleagues at the WHO trying to push and promote the IPS health Hajj card. And we have also partners from a couple of countries who were willing to join with us in this journey. I'm sure this is a very common slide that you guys have seen it before, but the IPS and the passport, the health passport, can be done in different, can be used in different, for people who want to take a picture. I'm gonna go back if I figure this out. Anyways, that picture is gone. Apologies, but I will be happy to share my slides with you. The work that we do is part of a major government work, not only the Ministry of Health, but it's MCIT, the Ministry of Information and Technology, the Ministry of Hajj, and the digital government authorities and others. This is a collaborative work. But the question that the team wanted me to highlight maybe, how did we make this this happen? Almost a year ago, we wanted to do IPS. 6 months into that, we successfully lobbied and convinced leadership to take on this project. Another 6 months, it's up and running. And now my colleagues here also were discussing with me this morning. We have findings. We're analyzing what happened. We have more than 250,000 IPS passport issued. Almost every one of those 250,000, if they ended up in emergency center, their IPS was used. 100% penetration in emergency setting. We found out that in primary care, it might not be super important because it's simple elements. But for emergency care, which is what matters, which is related to mortality or morbidities, we have 100% penetration. And how did we end up convincing the leadership? How did we end up making IPS core in our mass gathering management and in Hajj? By trying to highlight the value that comes out of that. And here are a couple of the elements that made it possible for us. We spoke about our collaboration with the right people, but also our ability to seize the opportunity from every one of these elements. When you have a growing number of participants, when you have COVID, that kind of paved the way for digital health to be at the center of discussion. And when you have an ecosystem that is willing to jump in and be part of the change and innovation. This is, in a nutshell, what we wanted to provide. And we're happy to have more questions during the panel. Thanks so much.
Okay, so let's do some quick introductions, and we're going to get in our panel discussion where we're going to explore opportunities and challenges around investing in and implementing digital public infrastructure for health. So on my left, I have Chrissy Martin-Meyer. Chrissy is a recognized thought leader in digital development with nearly 15 years of experience managing complex initiatives which deliver positive results for people. She's currently the Director of Policy at the Digital Impact Alliance, known as DIAL, where she manages several initiatives, including the Digital Donors Exchange and a learning network on unlocking climate data. Next, we have Sabine Dahani. She's the Deputy Director for the Technology Division at USAID. Next, we have Jack Hilton. Jack lives in Ghana and leads CHAI's digital transformation practice. He supports LMIC governments to coordinate digital health ecosystems effectively. Before CHAI, Jack worked with the UK's National Health Service, firstly with Deloitte, and then building several health tech startups which integrated into the NHS's digital public infrastructure ecosystem. Next, we have Dr. Alamud, who you've met already. And then after that, we have Carl Leitner. Carl is the Technical Officer for Architecture and Informatics for WHO's Digital Health and Innovation Team. Dr. Leitner leads the use of standards for Smart Guidelines approach and serves as the business owner for the Global Digital Health Certification Network. And finally, we have Hani Eskinder, sorry, who probably needs no introduction as you met him several times already, but he's the head of Digital Services Division at the Digital Society Division for the Telecommunications and Development Bureau of ITU. He's currently involved in providing assistance to several developing countries by advising on digital applications and services, and strategies and policies, assisting in implementing technical cooperation projects in areas of digital governance, health, agriculture, and education. So thank you to all our panelists for joining today. And let me just get to my first question. So to start, I'd like to hear from a few of you about how digital public infrastructure for health can be effectively integrated into a country's broader transformation efforts, particularly at the national enterprise level. Carl, let's start with you.
Yeah, so I think, part of the ways that you try to integrate digital public infrastructure in health. Is that better? Yes. Okay. So I think there's a number of strategies that you can approach in integrating DPIs in health, and it really depends on what the current country context is. So some countries already actually have a lot of DPIs, as Garrett had mentioned, that are in the health sector. So one question is, can we expand these DPIs to broader sectors? And so there might be a strategy of engaging with the Ministry of ICT. In other cases, those DPIs might not exist, and you might look for other sectors to try to take advantage of it. Regardless of this, there are digital health investments that exist in all countries. We don't want to, as we introduce DPIs, throw away the investments that are made in these existing systems. So it's really a strategy of understanding what these existing systems are, what their capabilities are, and starting to map these and the use cases, the workflows, the data exchange that are needed onto these digital public infrastructure. Critical to this is having standards, open standards that can be, that are endorsed by the government, right? The government is what's the driving factor in sort of the policy and setting things. Without that clear direction from a governance perspective at a national level, then there's sort of discoordination among the various partners. So with these standards set by the government, it helps to provide that direction and the strategy. And then you can look at these existing systems to see how they can map onto these standards. And it might be putting new functionality on these systems, or it might be putting facades. There's lots of different technical approaches here, but it's really going through and understanding what that enterprise architecture is, defining those goals, and mapping out that that roadmap for change, and doing through that change management process in a very structured way.
Great. And Chrissy, can you give us the view from Dial?
Sure, thank you. Yeah, so I think that's a great description of kind of the what we need to do, right? So it's going to be different in each country. Sometimes the health sector is going to be way ahead of the national kind of approach to DPI. But I would think if we kind of go a step further, well, then how do you do it? How do you do the kind of change management that he described, right? And so at the Digital Impact Alliance, we have a lot of experience working at the country level to try to create networks that really support that kind of change management. So for example, we worked in Sierra Leone on helping them on their digital transformation strategy. So again, this is a cross-sectorial strategy. But that was 18 months of like 15 different meetings across sectors, everything from government officials to the private sector to lawyers that were coming in, helping to just bring in a diverse set of voices to create the kind of trust that's needed to create this kind of cross-sectorial, and even if it's not going to work at every sector from day one, building in the kind of standards and just approach to reuse that we've heard so much about already today. And in Sierra Leone, this set the stage for a $50 million loan from the World Bank, so we are seeing real results when we do this kind of process. We also have something called the Africa Digital Leaderships Initiative, which is we're doing country cohorts of similar cross-sectoral groups that are really focused on data governance. And this actually isn't towards one specific, like, let's build a system, but it's in general, let's make sure that we're creating these kind of peer learning networks across sectors and across countries. So we're building these systems of trust, of exchange, of learning that can function for any kind of framework, whether it's a health framework or a national framework, and that can be adapted as needs and priorities change.
Thank you. And Jack, I'm going to pass it to you.
Sure, thank you. Hello, everybody. There's more people here than we were expecting. We were going to be down this small table, but there's too many of you. So, yeah, thanks for organizers for having us and hosting this. I guess I wanted to start with thinking a little bit about what we actually mean by DPI for health, because I think it gets a little bit confusing when everyone's saying that DPIs need to be sector agnostic and they need to be applicable to many different sectors, and then we're talking about like DPIs for health. And for those who were here during Garrett's lovely slideshow, I think that it was useful to see the 3 different layers of DPI, where at the bottom you had the DPI kind of core components, and in the middle you had what I think is being termed today and what we're kind of talking about of like DPI for health. But there is also this kind of gray area of using core DPIs for health, right? Which is neither the bottom layer nor the one, it's the kind of arrows that were between them, whereby you're kind of mapping, for example, your client registry to your national identity. And I guess the approach to which you decide to use that to kind of leverage all of that to complement your digital transformation journey in the health sector or more broadly really depends on which bits already exist and which bits don't. I guess a concern from our perspective and with some of the kind of country conversations that we've been navigating with the various different CHI LMICs that we're active in is that we don't want to kind of any momentum that exists with kind of building out that DPI-H layer in the middle, we don't kind of want to say, no, don't do that because you don't have a national ID yet. So it would be stupid to make a client registry, for example. And I guess for me, there is a concern that by putting a stress on these kind of core DPI components, we lose sight of kind of making more digital progress. And so I think it gets banded around a little bit, but what I like to use is like the DPI approach, which is, I think what we've landed on over the last few days, which has been really nice, which is we don't mean just those like DPI core components. We mean the DPI approach of building minimal modular software, which can be kind of integrated nicely. The trouble with that is that then we're not really talking about anything new. We're just saying what we've been saying for a while, which is like interoperability is super important, and getting these different things, different systems to be speaking together and doing what they do really well, but also complementing other systems becomes the thing that we should be focusing on. And I think in terms of how that complements your broader ecosystem, I mean, they're kind of one and the same, right? Your progress in digital public infrastructure has to complement in each country what is going on more broadly. And some of the places that we've seen momentum behind kind of a DPI-H model has been in Laos, for example, where we've seen some success in developing a health facility registry, which is now leveraged and is starting to be used also not only by the Ministry of Health, but also by Ministry of Posts and Telecoms over there. And so the question is whether we can sometimes use the kind of health sector to be that figurehead and to push forward on this kind of DPI approach and be used by other sectors, and in other instances leverage what already exists to build upon that within the health sector itself.
Thank you, Jack. All right, so for the next question, maybe we'll start with Abdulaziz. What are the major barriers to securing investment in digital public infrastructure for health, and how can we overcome these challenges?
Thank you so much. Yeah, I think what you just highlighted is really relevant to how did we, the approach that we took, and clearly it is a successful approach. So I'll talk about Saudi as an example and then take you through the journey of landing some investment related to the DPI implementation. So when the movement that comes around infrastructure has a lot of forces that pushes it and move it around. Health is one of it. And if you're able to articulate the health DPI for health needs in an approach that align with your DPI in general, with your national ID, or other elements, then you have, you always win an element related to investment or policy or standards or regulatory activities. That's why, for example, in Saudi, we have a national a committee that calls Health in All Policy, and we try to engage that with health in all investment approaches, health in all, let's say, strategic project that's going to impact the infrastructure. Think about it with this approach. You find yourself, exactly as you just mentioned, you find yourself already at the DPI for health without needing to dedicate and say, yeah, we want to take extra billion or so just to try to work on that. Because there are tons of competing opportunities when it comes to healthcare. But you need to be able to align what you do because it's similar to what other sectors need to do. I think this approach was very successful with us, and we think it should be implemented as it fits within different countries.
Thank you. And maybe, Hani, can I ask you the same question as well? How do you see overcoming the challenges of investing in DPI for health?
Okay, thank you. Maybe before I answer, I would like to say welcome. But welcome to who? Welcome to you, health guys. Seriously, you know, with Garrett and the team from WHO, we've been doing digital health and with so many people here in the room long time ago. The Global Digital Health Conference in Washington, with one assumption: the health sector can do it alone. And why? Because I think we were, and me one of them, we were locked with this innovation mentality, solution mentality. We say, okay, we develop solutions, we don't need to involve others. I mean, we as health sector, we know what we want, we are the best people who can define our requirements, and we can do it ourselves. And then after 15 years, the health sector is incapable of scaling up. Then the tsunami came. What is this tsunami? It's DPI. And thanks for India, G20, for pushing this huge wave. I feel that DPI is a wave that came from the digital government and is taking the other sectors with it. And this is one of the first times the health people are taking active discussion with the remaining digital ecosystem. And this is the move from what the innovation mindset to digital transformation. Let me say a sentence that I would like to repeat it everywhere. Innovation don't lead necessarily to digital transformation. Please repeat this if you are convinced to everyone. Innovation don't lead necessarily to digital transformation. Digital transformation is a systemic level. And the DPI is just a way for everyone to understand that if you really want to make an impact on the digital, on the health sector, you need to make sense of the innovations. So you need to think of system level. And if you think of system level, health is just one small piece of the stack. Yesterday, we had a very interesting discussion with the digital wallet guys. Health data is just health data. It can fit in wallets. You don't need to have a digital health wallet. It's just one wallet. It can host, fire, any sort of data. So there is no point of the health sector trying to solve the exchange. Africa, through Smart Africa, are setting SATA, this kind of platform for data, cross-border data exchange. Health is, if it's well designed with a DPI mentality in mind, it should be data agnostic. It should not care what is the structure of data. Do you want fire? Fine. Use it for fire. If you want like any other data structure, use it. So I think welcome to the health sector finally that we together discovered that we need to work not together. No, health needs to be represented in the digital transformation discussions to make sure that your health use cases are well taken when you design the health, the overall DPI. Then there are a couple of components that are specific to health, but believe me, there aren't many. Very few components, surprisingly. Most of the components are more generic than you think. So welcome, this is my first point. Second point is, we are starting some very interesting discussion with WHO to do a reference architecture for health. This is based on the great work. Honestly, I need to acknowledge the SMART guidelines. Honestly, I heard a lot of negative criticism about the SMART guidelines. And I'm not convinced with those negative criticism. They say, oh, it's not implementable, etc. I think what you have done is perfect description of the use cases to the level of going to the mapping with fire resources, and I think this is excellent work. Just give this to a couple of good architects. We have here one example. Don't trust them. They will be able to design the architecture very quickly. And this is what we need. But this will help only one small piece of what we need to do, which is the requirements. Help countries have the right requirements so that then when they spend millions of dollars, they get what they want in terms of health DPI. But here comes my most critical point, how to do it. If you go to a country and tell them, guys, build your DPI for health, it's good investment for you, it will not happen. Unless you have a very strong driver use case, it will not happen. That's my interpretation, and this is, you need a driving use case. Why? If you really are serious about building the health DPI and having EHR everywhere, etc., it's millions project, even in some cases multi-billion investments. And I was discussing with Egypt, and maybe Ahmed, you can make a comment after the panel. The universal health insurance in Egypt, it was costed multi-billion-dollar investment. By the way, DPI becomes like almost a no-brainer. I mean, yes, of course, do the EHR, do everything. I mean, all the registries that we are talking about, years of work, it will require millions of dollars. Unless micro use cases, forget it. This is not enough. And maybe this is another reason why we were not moving to the DPI, because we were very much focused on micro projects. You need macro projects, you need mega projects, you need mega use cases, you need millions and millions of dollars. So then the choice of the use case is the most critical, in my humble opinion, to make it happen. If we just go with goodwill and say, okay, let's put your infrastructure, this is good for the future, forget it. Unless you have a driver, comes with the funding, comes with the legal obligation, like universal health insurance or immunization. You need to have a mega use case, and that's why we need to talk to the mega guys. World Bank, Global Fund, Gavi, African Development Bank. Honestly, I don't find many other donors who can drive this. But my point that I wanted to mention is that two things. For those mega projects, the way you pull the project and manage the project is completely different story of any digital health solution project that you have been involved in. It's a national undertaking. It's mega. It's the model of implementation, project management, funding, and then you need to think of how you can sustain the investment. That's why I think the universal health coverage is one of the rare examples, because it's self-financed. It's self-financed. On the long run, you can self-finance the infrastructure. So anyway, it's a bigger discussion. I think maybe next time we should maybe focus on the use cases, because I think countries bought into the concept. We will develop the requirements, but even after all that, things will not move because you don't have the driver. Our colleague from Saudi Arabia told me an information which I will not share, but he told me how much you spent on the Nafis platform, which is amazing, by the way, and it's perfect reference architecture. And I think we can count like between 8 and 9 zeros for the cost of developing this kind of platform. So just to give you the mega level of investment that needs to happen if we are serious about deploying DPI. Thank you.
Thank you, Hani. So this is a good next question, and I'm going to pass it to Sabine and Chrissy. How are USAID and DIAL addressing some of the challenges and opportunities around what we've heard today, specifically around investments for DPI for health? So Sabine, I'll start with you.
Sure. So if people are not aware, USAID recently launched a digital policy. And so this is a 10-year policy that we've put out that really defines how the agency is going to be looking at our digital investments going forward. And a key component of the way we're approaching this is through an infrastructural approach. I think we've realized for many years of working in this space that this is really the most sustainable way to make our investments across all sectors. At the same time, our colleagues in the Global Health Bureau put out a digital health position paper where they also talked about aligning USAID's investments in digital health with country government investments in the health space. And again, taking this infrastructural approach. So I think, from the perspective of USAID and how we're sort of planning to spend our funding in digital, we really are looking at shoring up existing systems and investing, and moving away from sort of the more bespoke models. I will just say that, when we do our work, though, the government is really in the lead. So it's really key that the government has an approach here that the funders can get behind. We do offer technical assistance to help develop those approaches, and we do fund the Global Initiative on Digital Health, which helps, which is managed by the World Health Organization, and helps, finance the systems and the governance and the ecosystems of digital health. But we really need the governments to sort of buy into this approach and agree that this is the way they want to move forward and have a very clear vision about how it is integrated into a sort of a national DPI system. And then I think you can see an opportunity for, maybe not one funder, but maybe multiple funders to get behind this approach as long as it's sound.
Thank you. And Chrissy, over to you.
Sure, thank you. So I think some points that I've heard over the past couple of days that haven't quite heard yet, so I'll bring them in, are things that I think when we're building these systems to use open standards, to be reusable, to meet this kind of broader DPI approach, some of the things that we're setting ourselves up for are cross-border data exchange and also really powering private sector innovation. And I think that that's a huge opportunity in the health space as well, right? So bringing private sector in on the front end, on the financing through public-private partnerships, but also setting it up to make sure that we're leading to private sector innovation kind of on the consumer-facing end. So I don't know if anyone else has ever seen it, but Promote has this great kind of hourglass where you're bringing the, innovation in on both sides, and you're just really providing this kind of modular, interoperable stack of technology to help facilitate that, right? And it's really just the middle of the hourglass. And so one thing that DIAL is doing right now is we're helping the Africa CDC build out a health tech marketplace that is about to be launched in the next month, and there's already kind of a beta version of it. But this is in place to help them highlight local private sector innovation. So really bringing all of the great work that's happening across the continent and highlighting those innovations that are coming out of local innovators. And so the health tech marketplace is set up to be kind of a cross-border data exchange, but also to really power this private sector. And so I just as kind of one point to get to that, this is a very health specific at this point because it's the Africa CDC, but still something that I think could, in theory, go to other sectors. So again, kind of coming at it from either way, either going from the health specific to the cross-sectorial or vice versa.
Thanks, Chrissy. All right, so last question, and then we'll open the floor up. So first, what is the role of cross-sector collaboration in advancing digital public infrastructure for health? And how can we leverage international partnerships to accelerate progress? Sabine, I'll start with you.
Sure. So obviously, I think foundational DPI, like ID payments, data exchanges, can accelerate. Is fundamental to digital public, to DPI for health. So, and I think that there's obviously a ton of gains that can be met when different parts of the government work together to set these systems into place. But again, I think it has to be done across the government. And so one example I want to provide is that for many years, for USAID worked with the Ministry of Digital Transformation in Ukraine. And that was to set up their entire DPI e-governance system. And I think many people are familiar with it now. It's basically come down to like state in a smartphone, which is the DIA app, and it's very flashy. They do these great presentations about it. But effectively, DIA is DPI, right? It's digital ID, it's payments, it's data exchanges across a number of different registries across the entire Ukrainian government. And one thing that we saw that was very effective is the way that MDT approached this, and this was like a very top-down approach, right? So they hired a deputy prime minister that was in charge of this entire digitization project. Every single ministry within the Ukrainian government had to hire a chief data officer. They had to work together to get their registries to be interoperable. And this was a decades-long process to sort of deal with all the ecosystem level issues, connectivity, digital literacy, getting all the registries online. But it ended up being extremely effective now during the war. As people are moving across borders, they have access to their health records, they have access to their driver's licenses, they have access to their school records. And so this was something that USAID had supported for many years, and it actually now, when you talk about international partnerships, we've actually been working with the Ministry of Digital Transformation in Ukraine to share their best practices from setting up this system with other countries, right? Countries that have expressed an interest in understanding more about what they did and how it could be applicable in their local context. So now this is sort of how we've facilitated it, where USAID is not providing the technical assistance, we're more acting as the matchmaker to say, hey, we think that this is a system that could potentially be of interest to you, and provide in making those connections. So I think that's one example of how, you know, we can sort of facilitate some of these best practices and learnings.
Excellent. And so Jack, same question. How has CHAI leveraged its partnerships?
Okay, I'm going to answer a different question that maybe you didn't ask, but I guess that's been happening a lot these last few days, and I feel like it does a lot on panels. But I guess that a question that I want to answer is about the cross-sectoral collaboration. It's maybe asking the question of whether not just cross-sectoral, but like the right sector to be leading the way on this. Over the last couple of days, I've been listening to kind of a few success stories and reflecting on the work that a lot of CHAI projects are involved with. For example, in both Mozambique and Cambodia, they're at the start of their journeys of setting up a digital health department within their ministries of health, which is super exciting and a really good step in the right direction. The idea being that they will then become kind of responsible for example, a health information exchange and for maintaining various of their digital systems and coordinating standards, et cetera, et cetera. The realities, I guess, are, or a question is, and I don't know this for all countries, but in some LMIC settings, the talent and the kind of capabilities for running digital systems don't necessarily sit squarely in the ministries of health. The Ministry of Health doesn't tend to attract the geeky nerds who enjoy coding late at night. I'm looking at Estonians on the front row. And these are the people who are going to really kind of turn the dial on being able to maintain national architectures, right? And so in Zambia, for example, I was listening to the head of the Smart Zambia kind of institute, which sits in a kind of central location underneath their prime minister, and they have members who are working specifically on their health architecture within that kind of central DPI hub, if you like. Again, in Ethiopia, they have a kind of health innovation center, which is cross-sectoral, not just in terms of government sectors, but also in terms of building in universities and finding out, where are your capabilities so that we can actually pick those up and make use of them. And maybe instead of trying to kind of repeatedly work on capacity strengthening and encouraging these ministries of health experts in public health who maybe don't have and have never had aspirations to be interested in digital development, right? They didn't study this stuff, they're not particularly interested in it, but it is really important and we all kind of believe in that value. So I guess the question that I'm asking myself and now answering is what is the right sector and how do we land on the right sector within each country to best be able to deliver this stuff and then kind of force that cross-sector collaboration. And I think what's really hard from a development partner perspective, as lots of us on this stage are, is like, never is the answer going to be us, right? It's always going to be on the government side. And so how do we align ourselves, and certainly speaking humbly from a CHAI perspective, all of our relationships are with ministries of health in the 38 countries that we work in. And when we start flirting with the idea of working with more central ministries of finance, for example, to support the kind of development of their payments infrastructure to use it in health, there's hesitancy. Of course there is, right? We don't have relationships in the Ministry of Finance. Why would we do that? But actually, I think that's what needs to happen in order for this to be a more kind of cross-sectoral space. And similarly, for there to be a pull from the Ministry of Finance in the first place. So, yeah, a few thoughts there.
Thank you. Finally, Carl, can you talk about WHO's role in facilitating cross-border collaboration?
Yeah, no, I think there's a number of aspects where we play a role. I mean, one, we have something called the Digital Implementation Investment Guide that talks through how to plan for investments in digital health, and I think that's an important first step for governments to take in being able to articulate what their needs are. If they can't articulate their needs, they don't have a clear vision, then it's going to be hard to have that cross-sectoral engagement first. So I think as a first step, having clear requirements, having those macro use cases that are really driving things. The second, obviously, we've talked about the Ministry of ICT as being an important component and helping to facilitate those conversations. But the Ministry of Finance, and particularly with like health insurance, social protection schemes, is helping to drive some of those investments and innovations. The other thing that we're doing is we're working as well with a lot of the investors in this space to help them realize, that the investments that they're making, rather than being siloed investments for one health program, should really be thought of in a broader context. So that is sort of a cultural change that I think needs to happen, so that rather than investing in digital health for, let's say, M&E purposes, you're actually investing in digital health for health purposes, and then driving that secondary data use for reporting and programmatic monitoring from that. So I think what we're trying to do is change that conversation, change the way that investments are being done, and to give the control back to the ministries, to the governments, to set their directions and give them the power to articulate to those investors what their needs are.
Thank you, Carl. I'm going to open the floor to questions. I don't know if we have a mic runner. Do you have a mic? Maybe you could just speak loudly.
Is how to build the business case. Okay, before the financing, we have to learn how to build the business case, either for health or for DPI. Okay, this is very important. And I had a lot of experience in building different business cases in different occasions. Okay, we have to decide where the government is going to put and what we are going to get from the private sector, or what could be a self-sufficient driving force from the society. Cross-subsidization between different segments of the society or different quantiles also should be thought. Okay, this is a very important aspect. We have to look, when we discussed before with Skandar, discussed the issue of the health, building the health digital infrastructure here. Okay, we have discussed innovation way. We found that maybe the cost would be $1 billion. At least 50% of this could be financed not from the government. It could be financed from the entities that are working. Then the government has to finance maybe half of it. Building the business case is very important. Building the business case and understanding how much is the total cost of investment. Because usually people would calculate the amount of investment that they are putting, government looking what they're going to put from their pocket. It's not a matter of it. We have to look at the cost of the whole ecosystem. How the whole ecosystem costs. So project might be out of pocket for $500 million, but all the other partners in the project might cost us maybe pay another $1 billion. If we facilitate the income and we split, then we can bring successful private partner, public partnership. So the business model is key. Building private-public partnerships actually will help the governments actually elevate a lot of what is required, and it will also help mobilize private money into the domain. This is something that we have to look on how to build this innovative, how to build innovative financial models, business models first, financing, innovative financing, and also at look how we can mobilize the private-public partnership. Very small policy changes could be done. When you do the policy changes, then the private sector will come. When the private sector comes, it can elevate. And then it can manage the project more efficiently than the government. When you manage the project more efficiently than the government, because these are for-profit-oriented organizations, then the risks for the government will lower. We don't have to go into projects that are publicly financed. We know the stories here in England a lot, and huge costs. And then because of management, because of lack of clear vision, from the beginning, these projects would fail or would cost 10 times their original budget that we started with. This is a very important discussion that we have to bring on the table. and we have to bring it to the DPI. How to build innovative financial models based on PPP and different thinking in the business case itself. Thank you very much.
Thank you. Would anybody like to comment from the panel?
Sorry?
I said, would anybody from the panel like to comment?
Sure. So many things. Yes, I agree on one level that we need to convince people that. No, I don't think I do agree. I mean, health is not a profit thing to me, and I totally see how, like, in order to crowd in private investment and to improve the way that your health system is functioning, making the business case to accelerate the private sector, etc., is useful. But I just think that the health sector is so full of market failures that is not really the model that we should be pursuing. Like, the biggest problem that I see is that in the kind of like application for funding that we have to put forward, which is my version of a business case, if you like, we're going to global funders, and their currency is like impact. But their currency is like, how many malaria cases can you reduce over the next 12 months, for example? And building DPI is not the best way of reducing malaria over the next 12 months. Like this, it doesn't come into the equation in most of those conversations. Maybe reducing malaria over the next 15 years, then an investment in DPI does start to make sense, and the currency and the business case that I like to put forward, it becomes relevant. But the reality is, and we kind of skirted around the financing question earlier, but I wanted to come back on that, is that there is movements in the right directions, but we're still like, and I don't know how we get around this, because everyone is doing the right thing, right, from their own kind of echo chamber. The funders are trying to solve tangible problems and doing it in the most kind of lean startup kind of way, if you like, and that doesn't involve building DPI. Some of the bigger funders are now saying, let's build foundational DPIs, but they can't do that because it kind of needs to be done by the government, and so then there's huge problems with like handing that over in the long term. And so, yeah, I guess I kind of call to any funders in the room, and I know that USAID have done a lot of thinking and are moving in a certain direction on this, which I think is very welcome. But like, what do we do about that? And then secondarily, I've given my very UK NHS bias, which I recognize. But I do think that, like, yes, it's inefficient, but like, we save a hell of a lot of lives, which I'm very proud of. And I think that, like, if it costs a few more dollars, then that's okay. And yeah, so many things going off in my mind. But I'd love to hear from funders, like, how do we think about that? How do we square the fact that by investing in health system strengthening, i.e. global development, not global health, those two things have suddenly become kind of at loggerheads in my mind. One is like, you reduce child mortality, but it's kind of the West doing it to the global South. And the other one is global development. How do we square those things so that both can be achieved in the most efficient way possible? Because right now I'm struggling for those answers.
Hani, did you also want to comment?
Yes. No, I agree, actually. Not all use cases are good for DPI. I mean, we should not put the burden on each donor now and make him feel guilty that they are building siloed solutions. No, I mean, sometimes you need to build solutions that get quick outcome, agile, frugal, fine. And we need to continue about that. And by the way, we don't need, basically we just need one use case that can drive I always think about it as like a train. You know, like a train, you hook the the health ecosystem, and the train will pull it. But you need one train, you don't need multiple. And I think that's why the choice of the use case is really something that honestly I think we need to give much more reflection about it. I think we've been very much focused on why DPI, fine, how to design DPI, fine, but now how to implement DPI. And I think the issue of the business case, I think this is one of the key criteria for what is the business case. And that's why that doesn't lead necessarily to all use cases will not have a viable business case, because indeed sometimes the return is basically health outcomes. So that's one point. The last point that I would like to mention is about cross-sectoral coordination. Again, from experience. if you just leave the coordination on the goodwill of government departments, it will never happen. No way. This needs to be enforced by two things, by regulations. So for example, the first thing that you do for digital transformation is that you need to do a data law. What is a data law? Data law enforces all the government departments to comply with some sort of regulations related to data governance. That it is compulsory that if a ministry needs an information from another ministry, this other ministry is obliged by the law to share the information only related to the purpose of the use. This needs to be put in a law, that this exchange needs to happen through the data exchange platform that is put forward according to the government and respects some rules and procedures, etc. If this is not in a law, it will not happen. As simple as that. Governments is no goodwill in this story, right? So it's laws and regulations, and then a reference architecture. Reference architecture that everybody, again by the law, are forced to follow a reference architecture. This should be put, not the reference architecture itself, but the mention that you need any investments needs to have the clearance that it fits with a reference architecture that the government will publish by this authorized agency. So I think this is very key, that you need to make sure that this coordination will happen. And again, this goes well beyond the scope of the health sector. Health sector doesn't have control over all that. So that's why I think the health needs to be, I say we should not talk about digital health transformation. I say we should talk about health in digital transformation. Health is just a part of digital transformation. And this is what I think was the big lack of all what we have been doing, that we thought that the health can transform itself. No, the health will not be able to transform itself alone. And I hope that this is really understood. And by the way, we at the IT sector, we see ourselves your servants. We are not your masters, we are servants. You are the master because you understand the needs. We don't understand your needs, but we are serving you. So basically we are below you, just to make sure that there is no misunderstanding. I mean, we are serving the other sectors and not the way around.
Thank you. Maybe we'll take, somebody have a burning comment?
One more comment. One of the things that I think very important, and I deliver a lot of use cases, and I have a track record of success so far. A couple of failures, but a couple of track record of success. I think the process of quantifying digital health investment need to be translated into numbers that are, if you're taking this from the MOH budget or from other environments, the financial impact and ROI need to be structured with a clear direct, and there are ways to doing this, but there is, I think, room for more to move this forward, definitely.
Thank you. Do we have one last burning question?
Yes, very interesting story about the Hajj. When we devised the international patient summary or the patient summary in Europe, it was for unplanned care, so it wasn't just for emergency care. So I was a little bit surprised to hear that for the less serious encounters, it was so much less useful, if I understood you correctly, because there are a lot of simple things that might be forgotten even with a simple encounter between healthcare and the patient. Allergies, which is part of, for example, and implants and so on and so forth. Any comments on that?
Yeah, definitely. So if you, maybe if you envision the Hajj, people are, for 2 weeks, they're within the sacred kind of location. So if they go to healthcare facility, it is for a specific event. Usually, it's related to heat. You know, it's very hot. Mainly, this is why they're there for primary care. Maybe for small refill prescriptions, maybe URTI. I think, and this is the beauty of healthcare. You have to work hard to get it right. It's not easy. It's not it is rocket science, definitely. But for emergency medicine or for emergency care, this is a sophisticated condition where anything could help, and IPS is usually very handy.
Maybe just one, so as we were going through the requirements and we were thinking through the Hajj health card actually in practice, they're measuring the registration and the triage like in seconds, right? I mean, it's 1.8 million, 2 million people, and it's a really high throughput. So any, scanning that IPS and getting that information, that's adding to that time. And so I think it's also a pragmatism of like, okay, we have so many patients to see, let's only get for when we really know that there's some large issue that needs to address.
Thank you. We are a bit over time, so I'm going to thank all of our panelists. This was a really rich discussion, and I'm going to pass it to Hani for final closing remarks.
I think probably I think I concluded already, but anyway, welcome again to the digital transformation community, and I hope that this will not be the last time that there is a true collaboration across sectors. Thank you.
Thank you, everyone, for coming.